So good evening, everyone, and welcome to our Kawakib webinar series. Our distinguished guest today is a wonderful speaker and a dear friend to me personally. His name is Dr. Kenneth Bramall-Smith, who is a professor emeritus in the Department of Geriatrics at the Florida State University College of Medicine. I was lucky enough to meet Dr. Ken a few years back when he visited us at SHPPP, and he gave superb talks and we all learned from. And incidentally, also, Dr. Kenneth helped us rethink the end-of-life decision-making policies when he introduced us to what he called the pulse. So we keep on learning from you, Ken. Thank you very much. And thank you for giving us of your time to give this very important talk in relation to geriatrics. So Dr. Bramall-Smith founded and served as chair of the Department of Geriatrics from 2003 until 2015. He is co-editor or author of 5 textbooks and has written numerous book chapters and articles in the area of geriatrics, ethics, and geriatric rehabilitation. He has been selected 16 times by his peers as a member of the best doctors in America. I'm not surprised at all. He was a member of the National Advisory Council on Aging for the National Institute on Aging and a Health and Aging Policy Fellow with the Senate Special Committee on Aging in Washington, D.C. He is a past president of the American Geriatric Society and served on the Aging and Health Policy Fellow. Now there's a problem. Yes, and he served on the Aging, Disability, and Independence Forum of the National Academy of Medicine. He graduated from the University of Southern California School of Medicine, did a residency in family medicine at Glendale Adventist Medical Center, and a fellowship in the Department of Medical Education at the University of Southern California School of Medicine. He retired from FSU, though he continues to be involved in a lot of issues in 2017, and is enjoying playing pickleball, riding his e-bike, and I've seen lovely pictures on Facebook, hiking, Rotary service, and consulting. One thing I'd like to add before I close this introduction is being with Dr. Smith when he came was an experience on its own. I also had the chance to meet his late wife, may her soul rest in peace. And the amount of peace and serenity that one gets when one sits with them was amazing. And I'm sure you can tell this just by looking at Dr. Bramall-Smith. So Ken, I thank you again very much. The floor is yours.
Well, thank you, Talia. It's a very nice introduction. And it's wonderful to be back with all of you. I remember my trip to Beirut with great fondness. It was just a wonderful, wonderful experience. And I'm happy to talk about this. We've been involved in looking at the ethics of COVID since the beginning. I was asked by the University of Southern California to help lead a process for their faculty to get ready for the onslaught before it really hit, because as you probably know, COVID started, although it started in Washington State in a nursing home, it really just got terrible in New York for some time before it got bad in California. So we fortunately were able to prepare a little bit with the faculty at USC to be able to lead the rest of the team and especially for the students and residents to help them in coping with that. So I've been very interested in the ethics aspects of COVID from the beginning. I'm going to start a video, so I plan to do about 20 minutes of a presentation, and then we should have all the rest of the time for questions. So let me try and get my slides going here. And sorry. Can you see that now?
Yes, perfect.
Okay.
Very clear.
So this is the objectives. We're going to talk about the impact of COVID on older patients. That really is a key issue in thinking about ethical issues. Um, and then I'll get into the specific ethical issues that have to do with both acute care and with long-term care and home care kinds of dilemmas. I know that both acute care and home care probably were greatest in Lebanon or are greatest, but I would like to hear about your experiences. But the use of long-term care facilities, I know, is a lot less in Lebanon than it is in the United States. But I still think it's worthwhile to know about those issues because they really highlight what we need to be thinking about for the future. Because really the most important thing I think about these ethical dilemmas is that we need to learn from them because we're going to face other types of pandemics for sure. And then talk about what are the specific issues that affect older persons. And then I hope we spend a lot of time because I'd really like to learn from you about what has been your experience both with geriatric patients and with ethical issues. So this is information from the CDC, and what it shows is, as a reference, 5 to 17 years old, and it looks at cases, hospitalizations, and death. And you can see that in hospitalizations, there's just a huge rise in the number of hospitalizations, the risk of hospitalization for older people. But look at the death rate, it just is astronomically higher among 85-year-olds and even among 65 to 74-year-olds. So really, COVID is very much a geriatric issue. And I don't think that got as much press as it should have gotten. And in the United States, we have a severe shortage in geriatric physicians, geriatric nurse practitioners, geriatric nurses. So it's been particularly stressful on the geriatric care community. So why is it so lethal? Well, we all know that older people are much more likely to have chronic conditions and multiple chronic conditions. Dementia obviously has a much higher prevalence among old age. A recent study from the CDC showed there was an 18% higher death rate from dementia in 2020. So clearly people were dying from COVID with dementia at a much higher rate than normal. The reason, older people have much higher rate of disability and a higher rate of frailty. And although these two things are related, that doesn't mean that they're the same. And unfortunately, within the medical care system in the United States, frailty often isn't measured. So people don't understand that the person is frail and therefore has higher risk. I mentioned that nursing homes are common in the United States. About 5% of the older population lives in a nursing home. One resource I found said about 1.4% in Lebanon. I don't know for certain whether that's true. And then there are all these important social factors that affect lethality. So being dependent upon your family and having to, I'm going to turn off my phone here. Having to depend on them in order to supply your groceries and that sort of thing. Older people have income problems, even with Social Security. Education plays a big role because that is been shown to be related to how well people receive information, say from the CDC or from the public health kinds of organizations. And of course, then literacy plays an important role there. And so overall, older people have less access to information and may not be able to keep up with the current recommendations. And then, and by the way, there is in the references at the end, I found this interesting article about the impact of COVID-19 on older persons in the Arab region from the WHO, which is where I got some of this information. But ageism plays an important role in medical care. And this was a very interesting study that looked at a review of hundreds of different studies and looked at whether ageism played a role in the study. And you can see that they found that ageism led to significantly worse health outcomes in virtually every study. And this was in 45 countries, in 11 different health domains. Unfortunately, the prevalence of ageism increased over time, and a greater prevalence was found in less developed countries than more developed countries. But I thought it was interesting that older persons who were less educated were particularly likely to experience adverse health effects of ageism, and that it didn't matter who was perpetrating the ageism. The age, the sex, the race, the ethnicity of the care provider didn't make a difference. It still was common. And that is an important issue when we get to the question about allocation of scarce resources. So yes, we did have scarce resources, but really we had overwhelmed resources. I'll get to this more when we talk about ventilators. There were some places where there was no scarcity. In my large rural county, where we only have 2 hospitals, we never got to the place where there weren't enough ICU beds or ventilators, but there were a lot of other places that did. There has been a huge impact on healthcare providers, and I'll talk about that, especially around doing interventions like CPR and other types of respiratory sensitive interventions. COVID has had a big impact on vulnerable populations, and it's not just older populations, disabled people, minorities. It brings out the whole question of health equity and justice. I'm sure you've been aware of the Black Lives Matter and the controversies around those sorts of things in the United States. Racism has taken center stage, and many different organizations are trying to improve that. But it's really been aggravated by COVID. There's clearly a higher rate of infection and deaths among minority populations and among the poor. And the other thing that I think is interesting is, in most ethics, the decisions are between the treatment team and the patient and their family. And yet here in COVID, we have to think in a public health viewpoint. And so what that does is create this problem between thinking about the good of that one against the good of many. And at least in the United States, there's a tremendous history of belief in individual freedom. And so this extends from infections and use of ventilators all the way to the vaccines. And we're seeing a rising group of people who are anti-vaccine because they feel it's an imposition of the government on their individual freedoms. So these are the ethical dilemmas that I've thought about in acute care. The big one that got a lot of press in the New York Times and other places was allocation of scarce resources. And that extended not just from ICU beds, but to ventilators and ECMO machines and even CPR. And our usual approach, where first come, first served, is kind of the model, and we use our 4 principles of ethics in dealing with individual patients: autonomy, beneficence, non-maleficence, and justice, works well almost all the time. But when we had these huge shortages and people were backed up trying to get into the hospital, trying to get into the ICU, needing a ventilator, we didn't even have at one point enough room for all the bodies to go through the normal burial process, and they had to create these large refrigerated trucks that would hold the bodies until they could be buried. Caused us to shift to a public health ethics away from that first come, first served. But the problem with public health ethics is it's less standardized than this usual approach has gradually developed over the last 50 years or so. But the public health approach, even though public health has been around ever since people have recognized what epidemics are, doesn't have the same standard of approach. So here's an example of some public health ethic views that I think are actually interestingly different. Now, some of them fit with our usual ways. So limiting harm, you could say, well, that's non-maleficence. Justice obviously is in both the usual ethics and public health ethics. But for instance, the least coercive means, maybe that's non-maleficence. Reciprocity, that's really not in our usual way at all. So, and then you have these three different ones. I mean, this is from the third one is from the Hastings Center, one of the internationally recognized ethics centers, and yet it's different than the others. So I think this makes it difficult for frontline workers to know exactly what the right thing to do is. I'll take a little bit so you have a chance to look at those different features. I like self-effacing charity. I think that's a nice term. So the scarce ventilators problem started pretty rapidly. As I mentioned, the first case of COVID was in a nursing home in Washington, the state of Washington. And it wasn't long before a number of those patients at the Kenwood Center were in the hospitals in Seattle and put on ventilators. And they started having problems right at the beginning. But as I said, some communities had no problems. And so the problem wasn't so much that it was the ventilators were overwhelmed. It was that they didn't have enough in one place, but they had too many in another place. It was recognized pretty early that we needed to guard against making biased decisions about ventilators. So, for instance, using age or disability or religion or sexual orientation or criminal status, all were seen as we need to be careful not to use those as a reason not to put someone on a ventilator, because that would involve putting a value on that life. So instead, what we really should use is this concept of maximal benefit. Who is the most likely to recover if they get a ventilator? And so the other thought was if an emergency worker or healthcare worker gets sick, they should be treated because they're going to be needed to treat future COVID patients. So it's sort of like the model that's used in war, where medics are trained to treat the soldier who is least injured first so they can get back um, into the battle. Now, what happened was most states and medical organizations then developed a method for reviewing cases and deciding that would emphasize the objective criteria that would predict which person would have a maximal benefit, and specifically said that there ought to be limits set on using biased types of decisions. But it didn't always work out that way. In some areas, there simply just were not enough hospital beds and ventilators, and maybe more importantly, there was a shortage of trained staff, so that there weren't enough respiratory therapists, and people were using 2 ventilators per patient and that sort of thing. I'll be interested to hear how it was in Beirut. Um, but as I mentioned, there wasn't a problem of numbers, it was distribution. And so people tried to move ventilators from one state to another. But in a country like the US, where you're 3,000 miles away from New York, if you're in California, that's pretty tough to move a lot of ventilators. There also early, especially early, was a shortage of PPE. And this led to a lot of ethical dilemmas because you would like to provide immediate assistance to someone who has respiratory difficulties, but if you don't even have PPE to be able to go into the room or you're using makeshift PPE, then how does that play out in terms of your ethical responsibility to that patient? There also was a severe shortage of testing. This has improved significantly, as has PPE. But at the beginning, testing, not only did lots of places not have adequate testing for infection, but the turnover of the testing was taking 7 to 10 days. And that's just worthless because you're past the incubation period by that time. And so why bother testing? You might as well just go ahead and start dealing with the patient. Because of all these problems, some of the early triage recommendations that came out, like Italy's was probably the most infamous, definitely included age as a criterion for not providing intensive care. Now, the other one that I think is important is the risk to healthcare providers, and this gets into the impact of COVID on healthcare providers. So CPR is a very risky endeavor for healthcare providers from a respiratory standpoint. We've always thought about the risk from blood, but the risk from aerosols is even higher. And most hospitals required then that healthcare providers put on their PPE before they started CPE. But we all know that the time to initiation of CPR from the time of cardiac arrest is an important factor in survival. So people were faced with having to say, all right, I have my own safety to think about, and I have this hospital regulation to follow, and I've got to get all dressed up in my PPE before I start CPR. That causes a lot of moral distress. The thing is, the reality is many CPR attempts, at least in the United States, we're not going to work anyway. Our standard pretty much is anybody gets CPR who has a cardiac arrest and doesn't have a DNR order, do not resuscitate order. So it's kind of the standard of care rather than being applied when it's likely to benefit someone, likely to work. It gets applied almost all the time when someone has a cardiac arrest. That has caused a lot of moral distress in healthcare workers because you hear emergency personnel say, we're flogging this patient, we're giving them CPR, and we know they're not going to make it. Why do we have to do this? But because of worries about suits and because there wasn't clear guidance, people did it anyway. Ironically, COVID has allowed healthcare workers to make more evidence-based decisions about CPR. And there actually is a pretty big body of evidence about who is likely to benefit and respond to CPR, with benefit usually being defined as recovering a rhythm and spontaneous breathing good enough to leave the hospital. It's pretty easy to get someone's heart going again, but that doesn't necessarily mean they're going to leave the hospital alive. So some of these state or medical association recommendations actually came out with guidelines about how to make unilateral decisions not to provide CPR. And this was called informed assent rather than informed consent. So here's an example that was published in JAMA of informed assent. So the first thing is to assess the patient's values and goals. And this usually comes from a discussion about what matters to that person. So they give an example, and you'll be able to read these example questions or statements, but I use it a little bit different than this one. What I say is, basically, there are three things we can do in medicine when someone is very sick. We can do all the medical treatments we have available that are appropriate to try and save your mother's life, but it might mean a lot of suffering and it might not work. Or we can use other types of medical treatments like being in the hospital and getting an IV and giving medicines, but not use those very intensive interventions. And again, this is geared towards trying to save your mother's life. And it might work and it might not, but it usually does cause some suffering, not as much as intensive care does. Or we can do everything we have available. We can use intensive measures to provide comfort and not try and extend life, but try and make sure that your mother's life is as comfortable as possible for whatever time is left. Which of these do you think your mother would want at this time? So in that way, you kind of get an idea of the values and the goals that the patient has. And so you can say, is living a long time such an important value to her that it is above everything else? And if the answer is yes, then informed assent and making a decision on our part is not appropriate. But if the person says no, she really is concerned about being with her family and not having to live, in our case, live in a nursing home and that sort of thing, then that's when informed assent might be available. So then you discuss CPR and say, well, one of the things that's done in a hospital, if the heart were to stop, is that we try and start it again. It doesn't work very often, but if it does work, then that might be the only chance for survival. On the other hand, if it works, then the person is in the ICU. There's a high rate of disability after it, if it does work. Many times people live out their life in a nursing home. These are the problems with CPR, even if it works. So given that you've said that your mother's values are to be at home with her family and not to be in a nursing home, it seems to me like CPR would not meet those goals. So we're not going to provide it at this time. How does that sound? And so what you're doing is, rather than putting them in the difficult position of having to make the decision for their mother, you're saying the proper medical decision is to do what she wants to do. And CPR is not really what she wants to do. This is the discussion I use in discussing a tube feeding in a dementia patient. We know that tube feeding in dementia does not extend life once the person has gotten to the point where they cannot swallow safely, that it increases the burden of care and the burden of suffering. And so if I've started my discussion with the patient, hopefully before they become too demented, or their family after they have, and have discussed goals and values, and I know that their goals and values are oriented towards comfort and family life and experiencing life in the best way possible, then I say, well, one thing we're not going to be doing is putting a tube in her, because that would just increase her suffering. It wouldn't extend her life, and it probably would cause more medical complications, all of which don't meet her goals. So it takes a big burden off the family to use informed assent if it's used correctly. Now, the American Geriatric Society came out with recommendations for resource allocation, and they said that age should not be a determining factor, and that we should remember that comorbidities are linked to social determinants of health. So we want to be especially careful with older people not to make value-based decisions about a life being saved. And this is another reason why a feature that's sometimes used in prognosis of life years saved shouldn't be used. They recommended, like most of the recommendations that came from medical organizations, that a triage team be formed to provide an assessment. In our hospital, the ethics committee and the chief medical officer were the triage team, and that it be very transparent to anybody who's admitted to the hospital that this triage team would be assessing whether someone should use a ventilator, and that the doctor would not have to make that decision. Their personal doctor would not have to make that decision. So clear advanced communication was required, and patients needed to know that when they were admitted. And they highlighted the importance of advanced care planning. And Talia mentioned the importance of POLST, but advanced care planning and POLST really became a big part of the COVID response for ethical problems in older people here. Now, in the United States, somewhere between a third and half of US adults, older adults, have completed advanced directives, but there's been a big increase in this year. But we have to remember advanced care planning is a lot more than just filling out a living will or naming a surrogate decision maker. And the new direction that advanced care planning has taken is we really need to be discussing what matters to the patient or their family, not just what they want done or not done. And it's best done when not in the crisis. Now, obviously with COVID, that wasn't always possible, but still it is a goal that we're trying to achieve. So there actually has been a positive effect of COVID. There's been a lot more increase in advanced planning. You can see this is a study that uses an online advanced directive format, and you can see in February, March, and April, there was a significant increase in the number of advanced directives completed. Another study showed that advanced directives have been able to help people avoid hospitalizations and unwanted interventions. And it's really expanded the telemedicine approaches so that these can be done online. And it will be interesting to talk about the status of advanced care planning in Lebanon. So I'm going to end here with nursing homes. Nursing homes have been a huge, in some states, over half of the deaths have been from nursing home patients in that state, even though it's only about 5% of the patients in the state. You know, they're old, they live in these communal settings, often with a bunch of different patients, residents per room, like 4 residents in a room. They're all frail, they all have disabilities. They have a limited number of staff who have to provide this daily close attention, and a lot of studies now have shown that staff are one of the main vectors for extending COVID within nursing homes. And they often are demented or have decision impairment, which makes it very difficult to initiate prevention guidelines like PPE and understanding why they need to do that. So what's happened is this huge impact. In some places, they were locked down with no visitors from March and just recently opening. You saw pictures probably of family members visiting through the window outside their room. They didn't have communal meals. They're not having recreational activities. They had all these staff in protective gear. And so if you're demented, you know, you have enough problem recognizing a staff. And then why are they wearing these funny things? And it led to very high rates of depression and failure to thrive. It really brought out that nursing home care is broken in the United States, and a lot of people are talking about what needs to change to fix it. So that may turn out to be a good result of the COVID pandemic. So, you know, I've asked the question, what's worse, to die of COVID-19 or to die of loneliness? One study looked at the increased death rate of nursing home patients, said it may be due to loneliness and the increased use of drugs to treat behavioral symptoms of dementia, rather than just the fact that they have all these multiple illnesses. And Joanne Lynn, who some of you may know about her work, she's a really prominent ethics geriatrician in the United States, wrote this great article, Should Someone Live in a Nursing Home? Should Anyone Live in a Nursing Home? And that is actually a link. So when you get the slides, you can click on that link and see it. So I thought I'd end with this funny picture. So here's a picture from 1918 and the influenza pandemic. And you can see the whole family has their masks on. That's very good. But I really like that the kitty even has a mask on. So here's some questions, and you can ask your own questions. But you know, if we think age should be used as a criterion, then why not use gender? It's been shown that there is a higher rate of death among men than among women. So maybe we should just not treat men as well. If a younger person has a higher chance of survival even without a ventilator, why not prioritize the survivor to the older person then? If an older person asks to reallocate a ventilator to a younger person, should you follow that request? If we have to remove a ventilator from an older person because another person with a better set of objective odds for survival needs it, is that considered euthanasia? Why is it acceptable to consider age in vaccine allocation, but not in ventilator allocation. Is preventing families from seeing their loved one in a nursing home elder abuse? And same thing about quarantine, is putting an older, especially demented person in quarantine, elder abuse. So there's a bunch of references that really are good things to read if you want to dive in depth into this issue, and those will be on the slides that I will be sending to Tala. So that's it. Let me click this to stop sharing.
Thank you, Bruce.
Thank you very much. Thank you very much, Ken. It's very eye-opening and touching, and a talk that really resonates. Most of what you said are things that we are encountering in Lebanon. One of the hardest things, I guess, CPR, vents aside, etc., is the fact that when you have elderly in an ICU or on a COVID ward, and then you have all these medics and healthcare workers who were there, hazmat suit with the goggles on, and it's as if these people, the patient, already vulnerable, is being surrounded by, I don't know, robots itself.
Aliens, yeah.
It is dehumanizing. And even when they do the exam, there's no touch. There's something cold about the touch when you're wearing your PPEs.
Yes.
And the fact that family members are not allowed to come in, and most of the time they are the real support. In this part of the world, you know, the culture is family
Right.
members have strong ties between each other. So very tough issues. And of course, the effect of all this on the caregivers, on those who take care of the elderly people. So I'm not going to take the floor, although there's a lot to talk about, having experienced a traumatic event myself during COVID. But I'm going to give the floor to my colleagues if they have any questions, and I'm sure you and I can talk at any other point. So the floor is yours, colleagues. Is there any question, Dr. Smith, Dr. Brabble-Smith? Anything in the chat?
Let's see. No questions in the chat.
No questions in the chat. So we did face, and we are still facing, one big problem, which is related to the lack of ICU and to the lack of beds. Each and every week, I get at least 1 or 2 calls asking me to help find a bed or a room for a patient, or worse, to help them have access to oxygen, to an oxygen tank.
Well,
and you know, many people are hoarding oxygen tanks. Many hospitals are hoarding vents. So this is not helping at all.
Was there interchange between hospitals for equipment, or are they so independent that they don't do
They
that?
are independent. However, the government did receive a number of vents from several other countries. You know, we have an economic collapse now in Lebanon.
Right.
And there was a big scandal about not using them, about storing them, about them being not usable, etc. So it's let me put it this way: it's politics, health, and power. Unfortunately,
Yeah.
Healthcare is being seen as a commodity at its worst. Unfortunately, that's how it is.
Yeah.
And there is, I've noticed when I'm rounding on the floors, particularly if there's a geriatric population, I noticed that the healthcare team, kindly and with all care though, already assume that that elderly patient is not capacitated, which is not a right assumption.
Yes, that's common in US healthcare as well.
Yes.
Age and dementia are just automatically assumed to exist.
Absolutely, which leads to wrong decision making, which leads to asking others to make decisions when the patient, him or herself, can actually make any decision that he or she wishes.
Yeah, how is it in medical and nursing education about the training of the interviewing? One of the things that we started doing some time ago is using standardized patients, and we would really, always we'd have a standardized caregiver too come with them. And so one of the things we worked a lot on training the medical students in their interviews was not talking to the caregiver without talking to the patient first, and asking permission to talk to the caregiver of the older person, so that the student would actually get a demerit if they started talking to the caregiver without asking for permission first, to try and emphasize that idea of don't automatically assume just because there's a caregiver there that the old person can't make their own decisions.
So you see here, we do have standardized patients, and we do have a lot of training, and we even test them in OSCEs. But unfortunately, once on the floor, I don't know what happens, you see.
Okay.
And oftentimes, I remember one of the consults that I got was about someone in his 70s, and his daughter wants him DNR, his brother does not want him DNR, and there's a fight, and the physicians are at loss. And when I asked them about whether the patient is capacitated, they said, well, we're not sure. So that's when we asked a capacity test, and the whole thing changed.
Right.
So education is one thing, but most importantly is practice. And most important, even the more important than practice, is role modeling, is when they see their physicians, the attending physician, actually treating the elderly patient as a wise person, as we do in our culture. Usually elderly means you are wiser.
Yes.
Unfortunately.
Yeah.
Any questions from the floor? I don't want to take the whole session. I enjoy talking with Ken. Diana, no one is.
Yes,
Go ahead.
there was someone in the chat who
Okay.
was asking. Second, it was Erano was asking
Yeah.
if Dr. Smith can discuss from his point of view some of the ethical questions he introduced in the last slide. For example, elder abuse in the case of isolation and quarantine.
Yeah. So I think that it is possible that quarantining, the way it was done at least, is conceivably considered elder abuse, if we were to look at, were alternatives tried. So at first, the entire nursing home was closed down. And that, it may have been necessary at the very beginning when testing was so limited. But as tests became more accessible, and especially the rapid result testing became more available, it was many nursing homes, the better ones, developed special wards, COVID wards, and other wards where people had very limited risk. And some even went so far to develop wards where they went through, as Tali was just discussing, an in-depth discussion of the way that the patient or the resident and their family wanted to experience risk. And they would allow families to visit in those kinds of places. So I don't think quarantine itself is elder abuse, but I think if it's the only solution that the nursing home uses, it could be considered elder abuse, because there are other options. And I'm the medical director for a organization called Florida Association of Homes for the Aged, which is the advocacy group for the not-for-profit nursing homes and assisted living facilities in Florida. And we started with our members right away, educating them about alternatives to blanket quarantining for the entire population in the nursing home. So it's a complicated answer, but I do think that it would be, if it's a lot easier just to say, nope, you can't come in, nobody can come in. But I think, and we also, by the way, saw that more in for-profit nursing homes than in the religious based nursing homes. Most of our members in Florida Association of Homes for the Aged are religious or not-for-profit. All of them are religious or not-for-profit. So there was more of an incentive to do the right thing in those. As far as preventing families, the same thing. I mean, I do think that there are ways that we can get around the risks, and that a blanket prevention for all family visits is, the primary goal of a nursing home is to serve the health needs of that elder who's there. And they're not all elders, by the way. A lot of young people live in nursing homes too with significant disabilities. So if the primary goal is their health and safety, then I don't think that we can automatically say COVID is the worst possible thing that can happen. I think we have to accept that there is some risk to instituting these kinds of restrictions, and that risk may cause death, and hence we're really trading one form of death for another.
So Ken, since you mentioned it, and it's something that I always wondered about, when I visit elderly home cares centers, I notice, as you said, that there are often young children with disabilities living there as well.
Yes.
So I wonder whether this is a good idea for both. I mean, I think it will definitely affect the psychology of the older population, as well as seeing around them only people who have disabilities, and for the younger patients to live mainly with elderly. I don't know if this is a good idea. I have no clue. And the other thing that I also wonder about is that that decision to use a blank DNR statement in case of lack of vents. I'm sure you've probably heard about it. So what are your thoughts on these?
Well, for the first question, I don't know that it is the best situation for young people to be in the same type of facility as old people, young people with severe disabilities. Although often the type of young person with severe disabilities is often bedridden in a nursing home setting. So it would be possible to allocate rooms to similar kinds of patients. I do think it's very important that older people in nursing homes have access to younger people, but I don't know that access to a disabled younger person is the best situation. What some of our members have done is develop daycare centers that are in close approximation to the nursing home. And they develop programs where the children then visit the older people, and sometimes the older people visit the children in the daycare center. And that intergenerational type of setting has been shown to be a very good thing for both sets of people. So I think in many ways, America has done nursing home care in the worst possible way, and just shunting people off into these places where nobody else from a younger age or able-bodied people ever go is not the right way to treat our older population. And that this is where the new ideas around, I don't know if you've heard about them in Lebanon, the greenhouse model, which is where people are actually living in small houses around a central area where the nursing care for them is provided in that central area, but in their home, they're actually living in a home. And this is especially true for people who don't have families, because actually in our country, many people, it varies by ethnic groups. So for African Americans and Hispanics and Asians, they rarely have their elders be in nursing homes. They usually do home care. So, there is a greater desire to improve home care type provision. And interestingly, I didn't talk about this, but there's something called hospital care at home that was founded by the Hartford Foundation that really expanded during COVID. But I do think it's a good idea to get young people in touch with old people, just from a justice standpoint, and not even to mention quality of life. And the second one you mentioned, I wasn't familiar with it. What was that?
So there was a talk, I think, in the UK about issuing a blanket DNR statement, which means anyone is DNR in case, yes. So
With COVID, yeah. That was discussed here. I don't think any organization recommended it. It was discussed in Colorado and was discussed in New York. But I think people recognized right away that the blanket recommendation really was overkill, to use a pun, because at first, CPR was not very successful, even among people where traditionally we would think it would be likely to be successful. A young person, no chronic diseases, no metastatic cancer, all of the factors that go into predicting poor outcomes were not present, but they still were dying. But mostly it was because they really didn't know the best way to provide CPR for COVID. And so as soon, really in a matter of a month or two, it became clear that there were guidelines for providing effective CPR in COVID, and that we should use more objective criteria that have to do with the patient's medical status rather than just whether they have COVID or not.
Thank you, Ken. Any other questions from our colleagues? I have plenty, but I want to be respectful of your time. So I would like to really thank you, Ken, for this wonderful talk and exchange of ideas. And expect an email from me because I have a project in mind, as usual.
Okay, that'd be great. And I would love to hear about the experience you mentioned that
Sure.
it affected you personally too. So let's
Sure,
talk.
thanks. So thanks again, and hopefully between citation marks, see you soon.
Okay, I hope so too.
Bye-bye.
Bye-bye.
Thank you. Bye.
I'll send you the slides.
Yes, sure.
Thank you.